Okay, so on most of these PowerPoints, if you're someone who learns by reading, you'll actually see the chapter in the digital textbook that's on this initial first one, okay, this first slide. So you can go there if you want to read. That'll tell you exactly where to go. If you're a reader, if it's not a condition that's not on this PowerPoint, skip it, okay? Um, for those who are kind of planning on going on to nursing, I actually took a nursing medical conditions textbook and did PowerPoints specifically over those, okay? Now, different nursing textbooks have different content, but that's just kind of how I did these PowerPoints. Okay, so we're going to start with bacterial. I've got these broken down into bacterial, viral, and fungal. There's probably more viral than anything, but we're going to talk about bacterial first. So methicillin-resistant Staphylococcus aureus, that's a big, huge, long term. You've probably heard it called MRSA. Um, so basically what they believe this has come from is over the years of maybe over prescribing antibiotics or prescribing them when they weren't necessary, we've seen bacteria sort of evolve. So these types of evolutionary bacteria have become harder to treat. MRSA was kind of one of the first ones that hit. Um, it's very contagious. Uh, Direct contact, indirect contact, it doesn't matter. You can spread it either way. So direct means I have it on my skin, I touch you, you have an open lesion, or you get it on your skin and then you rub your eyes or you rub your nose or you pick your nose. Gross, but maybe you do that. Um, so you can do it that way. Indirect is I have it, I touch the door, you go out right behind me and touch it. We're both touching an inanimate object, and then you wipe your eyes, you wipe your nose, you touch your mouth, and so it transmits it to you, or you have an open wound somewhere. Um, MRSA, actually, once you've gotten it, can remain dormant in your nose. So it may not be it won't be an active type infection. It's just there and dormant, okay? Which means that potentially you could pass that on, again, gross, if you're a nose picker. Here's the thing that happens. I'm going to give you an example. We had a student when we had our athletic training program years ago, we had a student, and so they would rotate clinically to each one of us as athletic trainers. Um, so this student rotated to us, and one thing, there were two of us. I was covering softball, another athletic trainer was covering baseball, and both of us picked up on it. But it was a habit of his that he would, like, literally, he wasn't trying to pick anything out of his nose. It was just a habit of him sticking his finger in his nose and rubbing around. So we had to have a conversation with him about that when you're working in a medical facility, you can't do that. And this is one of the reasons why. You take that MRSA, then you're working on a patient if you haven't washed your hands. And let's be real, a lot of people don't even wash their hands when they leave the restroom. But you're working on a patient, or you touch a surface, and now you've left MRSA behind that someone else can pick up. So that's just a little something to think about. So there's two types. There's hospital acquired, which is just what it sounds like. You get it in the hospital, versus community acquired, anything that's not hospital related. And we kind of talked about that in pharmacology with bacterial infections. So this is anything except a hospital. So dorms, we talked about jail and prison facilities. I think we even talked about in pharmacology. Some farms will have migrant workers come in, and they will actually have housing that is dorm style housing. In fact, Eccles County, I think it's just south of us. Geographically, I'm not really picking up where it might be, but I think it's kind of south. Anyway, There's a farm over there that they have a giant metal building, and they have beds in the facility. They have bathrooms, showers, small kitchen. And the migrant workers, that's where they live when they come to work for that farm. And so they're all in close quarters. So that would be also a place you could get community acquired MRSA. Risk factors, if you're a healthcare facility worker, yeah, you can pick it up. The other side of that, you can transmit it to someone else. In nursing, you'll find, for those of you going on to nursing, they are going to pound into you the use of hand sanitizer. So when you go into a patient's room, you hand sanitize. When you come out of the patient's room, you hand sanitize. At the hospital I worked at, there's a hand sanitizer in every patient's room, and there's hand sanitizers all along the hallways. So they will pound that into you for that reason. Now I'm going to go ahead and tell you, not that it's dermatology related, but there's a GI infection that hand sanitizer does no good for. You actually have to physically wash your hands if you're dealing with a patient that has that. So just something to think about. IV drug users, obviously with the sharing of needles. If you've got someone who has a MRSA infection, they use that needle, they share it with someone, that can be passed on. We already talked about community acquired with incarcerated individuals, not only them, but people who are in close contact living quarters. From an athletic standpoint, those who are in contact and collision sports, which means they are contacting other athletic people or other athletes on a regular basis during practice. In fact, when all of this kind of hit, athletics was kind of one of the worst hit. Um, it was very easily spread. There's a lot of times athletes will just walk out the door with a small wound thinking it's nothing, and then the next day they come back and it's not what they walked out with. So it's really easy kind of to overlook. So we've already talked about that. How's it spread? Direct and indirect. Okay. It is not airborne. So that means if I sneeze or cough near you, that's not the way you're going to get it. You've got to get it through some sort of contact, whether indirect or direct. I talked about doors, but you also got to think about sharing towels. So this is where athletically we really kind of had to do things differently. So at the time, I was covering women's basketball, and we literally used to have just a tray of water bottles that everybody drank out of. So when MRSA kind of showed up, we had to actually start using individual labeled water bottles for each athlete, because you got to think, if I've got MRSA on my hand, I grab a shared water bottle, drink out of it. The next person behind me gets that water bottle, or the athletic trainer touches that water bottle to give it to someone. And that's a method of transport. Use of towels. The biggest change we had to make was the way that we cleaned showers, and changing the use of bar soap to some sort of dispenser, which I know you still have to touch. But you can also use some sort of washcloth that protects your hand while you're getting at least that. You don't have to touch a bar of soap. So there's a lot of things you have to kind of think about. What does it look like? So normally it's going to look like one of two things. Some sort of pimple that has gotten widely out of control quickly. Or it's going to look like a spider bite that kind of blows up overnight, and then you start kind of losing tissue. So either of those is going to be a pretty good indicator. The best indicator is going to be the last one. So through this class, where I'm going to talk about hallmark signs. All right, so a hallmark sign is a sign that usually points directly to the condition that I'm talking about. So the hallmark sign for this is going to be the size of the lesion explodes kind of overnight or really quickly. Probably all of us have had a pimple that just kind of, yeah, it got a little bigger over time, but eventually it went away. This gets huge overnight. You go from like a pimple to something like not even quarter size, like golf ball size, baseball size, softball size. So it explodes in size overnight. That's the kind of the hallmark sign here. Patients may have a low-grade fever. So low grade is usually a fever that's below 100. That just tells us my body's trying to fight off something, not necessarily bacteria. It could be it's trying to fight off the start of a virus. It can be something that is, you've got allergies. You get a little bit of a low-grade fever with seasonal allergies. But that can also be a sign. All right, so diagnosis and treatment. So hopefully you're remembering medical abbreviations, and hopefully you saw these in that class. So DX is the medical abbreviation for diagnosis. TX is the medical abbreviation for treatment. Okay? So to diagnose this, what they're actually going to do is culture the wound. Usually these are going to have some sort of liquid. So they'll take a Q-tip, they'll run it around in the wound, they'll send it off for culture. It used to take a lot longer to culture MRSA, but pretty quickly, because it got so widespread there for a while, the testing got better, just like it got better with COVID. You know, when COVID first started, we were having to wait several days to find out if we're positive. Now, you've got an at-home test. You can just walk right in there, do the test yourself, and in about a minute or two, you know whether you have COVID or not, potentially, if it's a good test. You can still get, you know, false positives. You can still get false negatives, so it's not an end-all be-all. Certainly, you can see pharmacological treatments with this. So that's going to be what? If it's a bacteria, you're going to treat it with what? An antibiotic. Remember, for this class, if you see a specific drug name, you do not need to know that for the test. You just need to know the class of drugs that treat it. Antibiotic. In bad cases of MRSA, you may actually have to have IV antibiotics, which means you're probably in the hospital for it. For most cases, if you catch them early, they're probably going to give you some oral antibiotics. In fact, if you can catch them super early, you can simply treat them with Hibiclens, which you can buy over the counter, and you can have the person wash that area at least once a day. Now, this will dry out your skin, but it will help kind of treat that if you catch it early. So you may get to skip the whole oral antibiotic phase of this when you catch it. Because yes. We're going to talk about impetigo in just a second. Yep. Mostly the differentiation is going to be lesions, which you'll see. Because we've talked about you can spread this through indirect, you want to wash, when somebody's diagnosed with this, you want to have them wash everything, their bedding and everything. Because if it's on their bedding, another place of their body touches that, they can transmit it to that. So let's say it was localized only to their knee. Well, they decided to sleep on their stomach that night. So the next night they sleep on their side, even they roll over on their side maybe that night. They touch that, happen to have an open wound there. Now you've got another area. I'll give you a prime example of indirect contact. I had a softball player who showed up in the athletic training room. She had like these pink pimple-like lesions all over her legs. I mean, from ankle all the way up to her hips. And so we started trying to figure out where did you get this? Because none of the other softball players had it. So I knew it did not come from that. I asked her about her roommates. No, none of them have had it. So we start trying to figure out, had anybody sleep over? No. In fact, she was living in the dorms. I said, do you have communal showers and bathrooms in your dorm, or do you have one only to yourself? She said communal. I said, went through the whole bar soap, any contact there. She said, actually yesterday I went down, she had a little basket that she had all her stuff in. She was unloading her basket, set her razor down on the shower floor, picked it up, shaved her legs. She got it from the shower floor. So you can see why we were like, hey, y'all got to start cleaning the bathrooms and dorms a whole lot differently, meaning like clean, clean, clean. For people that live together, we actually used to say, hey, go get a shower cleanser, spray it all over before you get in, bathe. When you get out, spray it down, especially if you're living, at the time, we were more concerned with athletes living together because we didn't want it to spread in that population. So we would say spray before you get in the shower, spray when you get out of the shower. That way, it's staying clean the whole time. With treatment, you want to keep wounds covered. It is the liquid that's coming out of them that has the MRSA that is going to spread it. So again, in the instance that I gave you, the person who lays in bed, they have one on their knee, they roll over, suddenly their hip is somewhere in that, keeping it covered will stop that, okay? You will see research articles that say as soon as it crusts over, you can stop covering. I say no to that because here's the thing, especially in the athletic population, that those scabs are going to get knocked off during practice. It's going to happen. So for me, until it is completely healed, like you have fresh, good skin coverage, cover it, okay? Because you do not want that to spread. And we've already talked about oral antibiotics and IV antibiotics. So prevention. Prevention is huge here, and it will be with any of these, really and truly. The biggest thing is hand washing. We talked about that in pharmacology. That is the primary prevention for the spread of anything bacterial, viral, and fungal, some of the fungal stuff. Making sure that you keep open wounds covered for MRSA, that if you've got a wound and you're in direct contact with a lot of people, that you get that assessed quickly, get it looked at. Shower often. I know that sounds crazy, but you got to remember, I come from an athletic background, and Finn, you're going to have to, is he here? Joshua Finn. Well, my football players, forgive me for saying this, and it's not football related. It's really baseball related. Athletes, the majority of them, y'all, they nasty. So let me tell you, the baseball team, when we worked with baseball, we literally had baseball players tell us, because we were checking for MRSA, and we were like, hey, your clothes, you need to be cleaning those. And they were like, oh, I rarely clean clothes. I just like get up and whatever's on the floor right there, I don't know if it's clean or not, and I put it on. Softball players, nasty. The one I talked about with the MRSA on her legs, yeah, that came from the shower. But she also used to go home right from practice, still in her uniform, and get in the bed and take a nap. Gasp if you want to. It's reality. So sometimes you got to talk about showering often. Now, that's not every person, okay? You're going to have people that as soon as they get home, they're like, shower. As soon as they get off the field, they're like, bump this, I'm going to shower in the locker room before I go home. That's what you want to do, okay? When sharing showers, use pump soap, not bar soap. Again, you can use a washcloth between your hand and the pump, okay? You can use a paper towel, pull out a paper towel, take it in the shower with you. If you want to use the washcloth to get it, doesn't matter, okay? Cleaning showers often, don't share towels. We already talked about that. All right, so questions about MRSA. All right, impetigo. So this is the next bacterial, still on bacteria. It can be staph or strep. So that's one difference between impetigo and this. MRSA is staph, or no? Yes. This can be either. This is highly contagious, just as MRSA is pretty contagious. So those are similarities. As far as prevention, and you'll find that people will tell you this with a lot of the bacteria that can reside in the nose, that using an antibacterial ointment Like mupirocin, that is an antibacterial ointment. So if you've ever seen antibacterial ointments that you put on a wound and then put a Band-Aid over, that's what this is. If you'll take a Q-tip, they say if you take a Q-tip and you kind of run that in your nose, it is a barrier. For those that have it, it's a barrier to not be able to spread it. For those who don't have it and generally like to rub your nose, it is a barrier, okay? So you'll see that sometimes in research. All right, signs and symptoms. So generally this person will be afebrile. So that is a difference between this and MRSA, because we talked about the fact that some of them may have low-grade fevers. That being said, these are the types of things you need to focus on to differentiate between conditions for this class. You need to focus on hallmark signs and what differentiates one condition from the other, okay? The other thing that kind of differentiates this to a certain degree is what the lesion looks like. So there are 3 forms of impetigo. There is a bullous, a non-bullous, and a combination of the two, okay? So bullous is usually the fact that you have some sort of papule or pustule. So remember papule, we talked about that in second block, and I realize some of you didn't take that this summer. So papules typically have a fluid in the lesion, okay? But it's not pus. That fluid is not pus. A lesion with pus in it is a pustule. So you will see one of those two things with bullous. Generally, they just have clear to straw-colored fluid in them and don't necessarily have pus unless the person's been picking at stuff, okay? One of the biggest places for bacteria to live is under the nails, which is why as a healthcare worker, if you're working in a clinical facility, you shouldn't be able to see your nails, which you can see mine, past the tip of your finger, okay? Most facilities are also not going to allow fake nails, okay? Because your nail, even if it's laid on top of your nail will separate and you will get gunk underneath there, and you will transmit that to other people. Non-bullous, it is usually going to be what shows up after bullous. So you've got these lesions that have this straw-colored fluid in them that have opened up, and so you're going to have that dry on the skin, which gives this honey-crusted appearance, okay? This picture is actually a combination of the two. So if you kind of look right here, you see kind of a red pimple. There's one. They don't appear to have pus in them. That one's kind of questionable to me. The picture's not really super clear. So you've got some bullous areas, but for the most part, all this is non-bullous. The lesions themselves have opened, and now you've got this crusted appearance all over the place, okay? Although it looks horrible, normally this is going to be pretty painless, okay? And then you've got some general common areas that it shows up. So again, this is different from what we just talked about because it's afebrile. Although I didn't talk about pain with MRSA, depending upon the lesion size, you may have some localized pain with that. Here, it's going to be painless. And then you may see, I skipped over this, lymphadenopathy. So that just means you may have an increase in lymph node size. And we looked at the location, I just kind of gave you a picture. But you would, obviously, if this was on the face, you would look for the lymph nodes in the neck to be enlarged. If it's somewhere, like let's say I got infected right here on my arm, I would look for the lymph nodes in the armpit to be infected, okay? If I somehow got it on my abdomen, I might look for the lymph nodes in the bend of the leg and the inguinal area to become enlarged and infected. So that goes along with it. All right, treatment. And I really probably should have put this on MRSA. Yes. That's a good question. For some of these, you won't really have a hallmark sign. Because you can see some of those things that we talked about with others. That is a great question. So if I don't have hallmark sign marked and I don't specifically tell you in class, hey, this is a hallmark sign, then you won't have one, okay? But you'll still be able to differentiate between the ones we're talking about in here. Because you got to think, for dermatology, most of the time, they're going to culture that to see exactly what it is. I didn't say this with MRSA, but obviously, since it's so easy to pass, you want to try to keep people away, that whoever's infected, away from other people. Them using their own stuff. Same thing here. You want to kind of quarantine them because it's so highly contagious. They should have put a bigger TV in here. I can't see that. So I should just look here. Initially, patients that have this might be treated for both impetigo, which is bacterial, and herpes simplex virus, which is viral. So they may treat both just to get it kind of under control, because you'll see they do look a little similar. Now that picture is a pretty severe case of impetigo. So when you look at the herpes simplex slide, you're going to be like, well, those don't look anything alike, because that's a pretty severe case. Topical antibiotics, again, just an antibiotic ointment that you can buy over the counter. If you've got much larger lesions like we just saw, yeah, they're probably on some sort of oral antibiotic for that. You want to wash the area daily, but you have to also be careful about this. When you wash, it is going to dry your skin out, okay? If you use antibacterial soap, it dries your skin out even more. So just be cautious of over-washing and over-drying everything. If you're involved in patient care, like if that were your child, you obviously would probably want to step up a notch and get some antibacterial soap for your hands and just kind of bathe with that until you get through the process of treating that person, because you don't want a second person with it. All right, so that's really the only two bacterial things we're going to talk about. So you only got two to keep separate there, okay? All right, with viral, this is probably the larger section of this. So the first one we're going to talk about, herpes simplex. This is extremely contagious, and I know some of you may be wondering, why are we talking about that with dermatology when sexually transmitted infections is part of this course as well? Why are we not talking about that there? Well, generally, that's all people think about, is that herpes is a sexually transmitted infection. It is not. What people generally call cold sores, that's the herp. I had a student one time, an AT student. We were talking about this in the gen med class, and I said, that's herpes. She was like, no, it's not. Cold sore is not a herpes. I said, go look it up. It's herpes. So you can see it is extremely contagious. I'll give you another story of how contagious it is. I had a female tennis player years ago that she had cold sores. So at the time, our tennis team, they always hung out together. About 3 or 4 days later, this is when our offices were in the PE complex. I'm walking past the computer lab, because where our offices were, you walk past the computer lab and then you got down to the athletic training room. I walked past and there were like 2 or 3 men's tennis players in there. I said, hey guys. They looked up and 2 of them had cold sores. I was like, I know who they've been kissing. When you've got an open lesion like a cold sore, if you are on a date with somebody with an open lesion cold sore, don't kiss them. If you have an open lesion cold sore, do not kiss children. You will give it to them. In fact, my daughter, bless her heart, gets them all the time. Somebody had to have kissed her as a baby with that. So you check. I can make a really rude comment here, but I'm not going to. You check those lips before you kiss. You got that? Yeah, it's herpes. Um, Here's the other thing about herpes. No matter where, and listen, let me back up. Genitalia and the mouth, not the only place you can get it. You can get it anywhere on your body. Okay? Um, let's say I have a lesion that's open. I walk out the door. I press. You come behind me. You press. You pick it up in an open lesion. Congratulations. You potentially have it. So it's not just in places you think. You can get it anywhere on the body. In fact, if you get it on places other than the mouth or genitalia, it's called herpes gladiatorum. Okay? It's just a different version. We've heard herpes simplex 1, herpes simplex 2. There's others. The thing about it is, once you have it, it is with you for life. Okay? It actually will go and lay dormant in your nervous system. And what will cause an outbreak is some sort of stress to your body, whether that's emotional, physical, like you get really sick, you may have an outbreak. What was I going to tell you? I was going to tell you something else. Can't remember. So really, the fact that it lies dormant and you have outbreaks, it's a lifelong disease, no matter where it's located on your body. Okay. So signs and symptoms. So again, you can see looking at this picture why, well, that's really small versus that impetigo was really huge. The thing that makes people or physicians want to treat both is that initially, if you have a true bullous without any pus in the impetigo, then it will look potentially like this. You'll have these little clusters of lesions that have straw-colored to clear fluid in them. So they look very similar. So until they really do a culture and get that back, they're going to treat both sometimes. I think the hallmark sign for this, and it's not marked, but the hallmark sign to me is this: they tend to cluster into one area. In fact, I always remember it as a cluster of grapes. Looks like a little cluster of grapes. So there's a lesion, there's a lesion, there's a lesion, there's one, and there's one. They're really close together. Now, yeah, you might have one kind of out here on the end that doesn't look like it's connected, but it kind of is. But generally, that's what it's going to look like. The first sign for most people is an itching sensation. So it'll kind of feel itchy, maybe a little tender. And then the next day, it's kind of grown and it's gotten more tender. I think another hallmark sign is that your vesicles will typically have a really red base. So if you look around the edges, that's all red. And in areas where there's not a lesion, it's red as well. So clustered and then a red base. As it progresses, pain levels will increase. They'll last maybe 4 days-ish, and then it'll kind of start to tail off. The lesion will still be there, so you're still concerned about it opening and potentially spreading. So obviously, keep that covered as much as possible. Now listen, nobody wants to walk around with a Band-Aid on their face, but also, a little education goes a long way. Now you know if you see that on an individual, not the person you want to be kissing on. Okay, so diagnosis and treatment. They will unroof it, take a culture of it. So unroofing just means opening a closed lesion. So you basically just open it up, culture it, test. Keep contact minimal, cover it if at all possible, depending upon the location. They'll give you antivirals. And here's the thing with this, so for people who have lifelong exposures, you kind of start to recognize, oh man, I got a cold sore popping up. If you've been prescribed an antiviral, sometimes they'll go ahead and say, the doctor will say preload, meaning take a couple of pills, and you won't actually have a full explosion of the herpes lesion. So it'll kind of keep it at bay, and it'll be a lot less painful, won't last as long. So that's just a thought. Questions about that? And we'll revisit it again with sexually transmitted infections as well. All right, varicella zoster. This is just another term for chickenpox, which is also very contagious. In fact, it used to be back in like, I don't know when it started, but I know it had to have been at least 40s, 50s. My mom said that when one kid in the community got chickenpox, everybody who hadn't had chickenpox loaded their kid up, took them over there to let them get it, which seems horrible. But here's the thing. You can fight it off better as a child. I wouldn't do that for an infant because their immune systems aren't up to par yet. And as you age, like if I've never had chickenpox, if I were to get chickenpox, it would be horrible for me to fight off. And the older I get, the worse it's going to be to fight off. So that's the way they kind of used to handle it. It is spread through respiratory droplets or direct. So either way, you can cough, sneeze, and transmit it to somebody. An open lesion or touching yourself, like scratching and then touching someone, you can pass that along. Patients are going to be contagious from about 2 days before the onset of the rash. So all of you should have learned this during COVID. If you didn't take anything from the COVID crisis, here's the one thing you should have taken from it. There is no way to completely prevent the spread of COVID. From the minute you get it, it takes 2 to 3 days for you to see the first signs and symptoms. From the point of you being infected till that second to third day, you can spread it to someone else. There is no way that we'll ever get that under control. Same reason we won't ever get flu under control. Okay? So there's going to be a period with viral infections where it seems like you're okay, but you're really not. And the virus, that's just the point that the virus is taken to build up in the system. And when it gets built up in the system, boom, your first sign or symptom shows up. Okay? Young children may develop few or no lesions. Again, they're more equipped to kind of fight that off. But then as you age, you tend to have more and more extensive eruptions of this. So signs and symptoms, low-grade fever. You can actually have that with herpes simplex virus as well. Headache, HA is an abbreviation for headache. You'll see that sometimes on my PowerPoints. Malaise is just them generally feeling tired, not feeling well. A papular or vesicular rash. So it'll either look like a vesicle, meaning it's got fluid in it, and that's for you, the ones that didn't take second block. So a vesicle has fluid in it. A papule is a little cyst that doesn't have fluid in it. Okay, so it'll show up as either of those. Generally, it will start on the trunk and spread to the extremities. I'm going to tell you that's not a hallmark sign because you're going to see that again on some other ones in here. Infants are now receiving the vaccine for this, so it's becoming less and less common. Still happens, it still will happen potentially. That is not something that has been eradicated. And in fact, Russ and I talked several years ago that he had seen an article or seen something in writing, it might not have been an article, where it had been eradicated. It hasn't. We dug more into that, and it hasn't been fully eradicated. Okay, so last class period, we talked about varicella zoster, which is chickenpox, okay? This is linked to chickenpox. So herpes zoster is linked to chickenpox, okay? It is an actual reactivation of the chickenpox virus. We know it as shingles, okay? We typically call it shingles, but it's an actual reactivation of the chickenpox virus. Um, I didn't mention this, I don't think, with, um, oh my gosh, with herpes. I didn't mention this with herpes. To a certain degree, I did. But remember, it lies dormant in the nervous system. An outbreak of physical stress, emotional stress, um, causes an outbreak, and usually that outbreak reoccurs in the same area every time. This does it in a similar way, but it actually does it in a much larger fashion. So with this, it typically follows a nerve pattern or a dermatomal pattern. So this is a little bit different in that it doesn't quite depict that linear fashion that it shows up in. So this is a reactivation. Usually you will see it in a linear form, and here you don't. It could be that in this particular person, it's in several different nerve roots. And so you don't quite see the linear pattern that comes from it. But that's kind of what you'll see. Normally, for whatever reason, they tend to show up more so around the back and abdomen, these patterns. It's usually where you have the reactivation. Don't know why that is. You see it a lot more in older individuals, but not always. I mean, I've seen it in 30-year-olds that have had chickenpox before and got a shingles outbreak. So some of the signs and symptoms are very similar to herpes simplex in that you get this itching, tingling sensation beforehand that becomes very painful. This is very painful. In fact, since it's on the abdomen, most individuals will complain or say that even their clothing brushing across it causes them some extreme pain. Okay? So this is extremely painful. It looks much like, although to a larger fashion, the herpes simplex virus in that it's got the red base, the vesicles with fluid in them. You can see some more systemic type stuff like feeling tired and having enlarged lymph nodes. Okay, so you can see that with this. Doesn't always occur. Here's one thing I want to tell you about these medical conditions. And it's just like anything else medicine related. There really is no black and white. There's a whole lot of gray. You won't see all of these signs and symptoms in every individual. You may see one or two of these in one individual, three or four different ones in another individual. So you have to be careful of saying all these signs and symptoms have to be there for it to actually be varicella zoster or herpes zoster. Okay. All right, treatment. So because it's viral, yes, we can give them antiviral meds. If you catch it early enough, that helps. If you're in full breakout, it's probably going to knock a day or two off. That's what we've talked about before. Other than that, it's more about treating the symptoms. So if there's itchiness, we try to treat that with either something like an antihistamine, or you can do something topical like calamine lotion, which helps with itching. However, you have to be careful. You don't want to break any of those vesicles open because you certainly don't want any kind of spreading with this. You also want to be very careful about opening for the reason that you may transmit bacterial to them, which would cause a bacterial infection. So we want to be very cautious about that. Any questions about that? Okay. Reactivation of varicella zoster, which is the chickenpox virus. So next we want to talk about human papillomavirus. You've probably heard of this, HPV, but you've probably heard of it more related to probably sexually transmitted infections, or you've heard the HPV vaccine talked about. So HPV is the causative agent across the board for warts, no matter whether that's sexually transmitted infection, which is known as genital warts, or whether it's just warts somewhere on the body. HPV is the causative agent for that. You see it most commonly in children and adults. Honestly, HPV lives everywhere. Most of us get HPV, but our bodies generally do a really good job of fighting it off. Except in some individuals, for whatever reason, it says, okay, HPV is here, it's caused these warts, but we're just going to include that as part of the family for the body. In other individuals, it sees it as, oh, this isn't supposed to be here, let me attack it, and it never really turns into a wart. So um, it's all around us. Spread by skin to skin contact. Usually, if you have intact skin, not a big deal. But if you've got an open, even the smallest of lesions where that can get in, that's where it tends to start to cause problems. So, for signs and symptoms, you can see an array of signs and symptoms. On some individual, it will look like a smooth, dome-colored papule. Okay, um, papule, remember from health assessment promotion, means it's like a little cyst. It's hard, doesn't have any fluid in it. No blood, no pus, no fluid. Okay. In other individuals, it may show up as a rough surface papule that also has what's called seeds in them, which is, you've probably heard of that. What we call seeds are not actually seeds. They're actually thrombosed capillaries. So small little tiny capillaries that have burst at the base of the wart are what gives it that dark appearance that looks like a seed. And that's all it is. Um, so you can have those two different appearances, okay? Either smooth top, rough top, seeds, no seeds. So you can have a combination of all that, unfortunately. Again, these can occur anywhere on the body. Probably the worst place to get them is actually on your foot, on the plantar surface of your foot. Um, Particularly with athletes, that becomes a problem. All right, so some conservative treatment versus non-conservative. So conservative treatment typically means we're doing everything we can not to have some sort of invasive procedure, okay? We're doing everything we can not to do some sort of invasive procedure. So invasive to me means an injection. Um, we're scraping it off. We're completely freezing it off, because even freezing it off is going to cause an open wound. Cutting, um, all of that would be conservative. Non-conservative, we're staying away from that. So for HPV outbreaks, one of the things that we want to try to do is try over-the-counter salicylic acid applications. Those either come in patches or liquid, and you just simply put it over the top topically of the wart. And what really happens over time is that it moistens the outer layer of the wart. When you pull that off, sometimes it pulls layers of that. You put another patch or another layer of liquid on it, and usually you cover it with a Band-Aid. Same thing. It moistens it, you pull it off. So that's why these over-the-counter treatments take so long, because all you're doing is pulling off thin layers of the lesion itself, okay? Um, I've heard of people even using this, and it worked, duct tape. So putting duct tape on it, it retains the moisture. When you pull it off, you're pulling off a layer. You're doing the same thing. So take that as you will. I've never had it, never tried it, so I don't know. For more invasive procedures or advanced care, liquid nitrogen, freezing it off. So with that, typically you're going to cause an open wound. So that's why we consider that to be invasive. They can laser treat those. And I'll tell you about this just because my daughter went, I took her last week for this very thing. She has two right on her elbow. Um, the dermatologist actually took and they did a topical numbing medicine. Then she scraped the top of it. And then they actually they call it beetle juice, and it's actually from a beetle. And what they have found through research is that whatever they're getting out of that beetle, they put on the warts, and over about 6 to 8 weeks worth of treatment, they're gone. They don't return. So that was interesting to me. I'd never heard of that, but that's what they're using in the dermatology office here in town. Questions about any of that? Okay, so that ends the viral dermatological conditions. Now let's move on to fungal. So with fungal, anytime you see the word tinea, Tinea, and I've got it here called tinea infections because that's kind of an adjective. So anytime you see tinea, Tinea, it means fungus. Okay? So if on the test I ask you, how do you treat a tinea blank condition, you would tell me what? Antifungal. Okay? Because all of them really are going to be treated the same. They're all fungus. We're going to talk about several different ones. This is not an exhaustive list of fungal infections, okay? There's a whole lot more, but I'm just kind of choosing to cover these. So Tinea corporis is what we generally think of as ringworm. So you've got this red ring appearance, and then sort of in the middle, you've got this normal skin tone. Yes, you can still see some discoloration right there, but for the most part, this matches normal skin tone more so than the redness. Okay, so Tinea corporis is called ringworm. It's what we consider ringworm. It's spread through skin-to-skin contact. Most of these are going to fall under that. And then the other thing with fungal infections, a fungus loves what kind of environment? Dark or light? Dark. Moist or dry? Warm. Exactly. Those three things are right where a fungus wants to live. Okay? So some of the some of the conservative treatment is going to surround itself with letting it air out if possible. Now, some of these, and you'll see, you're not going to be able to let air out unless you're at home alone in your room. So, just because of its location. But that would be one of the things that we would want to do. We would want to make sure the area is really clean and dry as much as possible. Those would be some conservative treatments for this. All right, next one, Tinea cruris. Here's the one you're not going to be able to just let air out in public. It's jock itch. So you typically find those in the inguinal lines, which are where your abdomen meets your legs, okay, right at the hip. Those are your inguinal lines. It can affect other areas. So it can affect perianal. It can affect the perineum. Because those, again, wherever there are folds of skin and dark, warm, moist environments, it's where this stuff loves to live. It generally affects men more than women, I think simply because they have more folds. It could be something from a physiological standpoint that I just haven't run across in a textbook or in research. So that could be another reason why men more so than women. So Tinea cruris. And you'll need to know the different names, if you notice, have some differences in location so far. So corporis can really be anywhere on the body. Cruris is going to be somewhere in the inguinal lines or perineum, perianal area. All right, unguim. So anytime you see the word unguim, it typically means nail, okay? Nail. So this, we usually see this on toenails, but it can occur on fingernails as well. Especially with, I think you would probably see it more with fake nails that get a layer in between the fake part and the real nail, and people who keep their hands in water a lot, like washing dishes, doing whatever. I think you could very easily see a fungus get in between the fake nail and real nail. It causes a thickening of the nail. It becomes lackluster. So normally you'll have a little bit of shine to your nail, but with this you won't. It will thicken and it will only get thicker and thicker over time. It can cause your nail bed to separate. Once you have your nail kind of separate from the nail bed, you're likely not going to get another nail to grow back. Okay? Because once that grows off, If it's separated from the nail bed, it's got nothing to help kind of grow from the base, because remember, your nails grow from the base, from the nail bed out. You can do topical antifungals for this, but I'm going to be honest with you, they're typically not very effective. So normally you're going to have oral medications prescribed to these individuals. I think let me say this, newer antifungal medications, just like any other medication, when it comes right on the market, is going to be expensive. Over time, I think since more generics have come on the market, it's more affordable. So the oral medications aren't as costly as they used to be. This is a big one for letting your feet air out, dry out, keeping them open to air as much as possible. If you're someone who tends to wear shoes at home, but you get this fungal infection, take your shoes and socks off when you get home. Let it air out. This, was it? No, not this. Next one. I'll give you the next one. Yep, tinea pedis. This is the one. So, athlete's foot. Here, you've generally got the fungal infection that winds up in between the toes or in the bends of the toes underneath, because for some people, their toes just naturally curl under more than others, so you can certainly get it there. This one is able to grow. So this is an example. We had a baseball player here years ago that he loved wearing like combat style boots, no matter what. Now, obviously, he couldn't on the field when he was playing baseball. He wore cleats then. But any other time, he didn't care if he was wearing shorts. Did not matter. He was in combat style boots. So he came in about athlete's foot, and we said, hey, when as much as possible, you need to clean and dry the area, which he was not a very cleanly person. You need to take these off as much as possible and let this air out. He didn't, and eventually his athlete's foot started growing up his calf and actually got past like even where your Achilles tendon attaches to the actual gastroc muscle. So it grew that much. So that can happen. So if you don't take care of it, it will get worse. This that you're seeing here, okay, that is, I think, not related to this athlete's foot, but I do think this is, simply because of its location, and this because of its location, really. But what can happen, you can see these reddened areas, and you see right now it looks really dry, and that's probably because either they've gotten medication that's dried it out, or they've actually been doing what they're supposed to do and getting it out, letting it air out and dry out. If you remain in shoes, your skin can get really wet and macerated. And so, one of two things, it can stay so wet that it actually tears open like this, or two, you get it so dry that it tears open like this. The reason I kind of say I don't think this is related, look how clean and sharp the edges are to that. That almost looks like some sort of, not that I think it's an incision, but something that caused a really sharp, versus you can actually see these are a little bit ragged right here, which tells me they tore open. So this is related to the athlete's foot itself. Okay, so you'll see that sometimes. That's not going to be part of the appearance. It's kind of secondary because it's either so moist or way too dry, one of the two. You can see a classic ringworm appearance. I just think it's harder to delineate that when it's in between the toes. Unless you can really get the toes spread apart and look, that's not going to be noticeable to you. Questions about any of those? All right, so let's talk about some general fungal infection care and some signs and symptoms. So you might find some itchiness. You're definitely going to find red areas. Remember, we talked about each one, the red areas being a little bit different as to how they look, i.e. regular ringworm versus jock itch, athlete's foot versus the nail fungus, okay? Those all look very different. Some can be asymptomatic, but you're not going to typically pick up on that if you're not seeing these classic symptoms with some of these. So as far as diagnosis, they can take, usually it's by visual inspection, but they can take a scraping of it. I'll give you a prime example. Um, Small infection on the back of the neck, totally looked like it started out as psoriasis, treated it like that, started getting a bacterial infection because you could see little pieces of pus, referred, got some antibiotics, got a little better, started coming back, referred again, and they actually took a scraping, and it was a type of fungal infection. Did not look like your classic ringworm appearance that you would see on the body. Um, it totally looked like a little clump. It was just odd. Um, Refer questionable lesions, persistent symptoms, even though you're treating it like you're supposed to, because something else is going on. For most dermatologic conditions, if it's a vesicle, we talked about this, they'll unroof it, take a culture, or they'll take a scraping and either look at it under microscope or let it grow and then look at it under microscope. So they know exactly what they've got. As far as treatment, most of these are going to be fairly conservative. You can use over-the-counter antifungal treatments. They work fine. Takes time. If the lesion is not responding to over-the-counter, you probably need to refer for something stronger. Be sure that you're washing the area, that you're letting the area dry, and that you're keeping it open to air as much as possible. This is one of the first slides where you're actually seeing actual drug names. Remember, for the test, do not remember specific drug names. You will be wasting your time. If I give you a fungal infection, I just want you to tell me we're treating that with an antifungal. Okay? Last thing, be sure and launder clothes daily because you don't want that spreading to other areas of the body. And once it gets better, if you're not cleaning your clothes, you certainly don't want reinfection. So we want to stay away from that. Questions about any of that? Okay. All right, so we're done with bacterial, viral, and fungal. And so now I've got a couple that I just kind of lumped here at the end because they kind of don't fit anywhere, but um, you'll come across them. So skin cancers, we talked about this in health assessment and promotion. And we talked about from an assessment standpoint, the whole ABCDE assessment. Is it asymmetrical? What does the border look like? What does the color of it look like? What's the diameter? And has it evolved? Y'all remember that? You just want to ensure that if anything is evolving, so if a symmetrical becomes asymmetrical, if a clear border becomes irregular, if the color changes to a darker color, the diameter grows larger, those are all things that tell us this needs to be assessed by a physician, okay? So that's just kind of a recap. There are different types of cancers. So one of the most common that you'll see are basal cell carcinomas. Um, these really are early cancer lesions. They can start out as small little red areas, usually flat. Sometimes you can see bleeding. So in this one, you can kind of see some dried blood right there. But usually they're flat, kind of red or pink in color. The squamous cell, which is the next one, you see more of a nodule. So instead of it being flat, remember with nodules, those are raised. They're solid. They don't have liquid in them. But you can have some scabbing over that, sort of a scaly lesion over the top of it. We are not talking about Merkel cells. It's just that this particular picture showed the three that I wanted to talk about. So melanoma would be the one that we're much more concerned with. It's usually much more evolved, so you're going to see a larger lesion, has the dark colors, the irregular borders, and is asymmetrical. So it kind of has all the big hallmarks of what we talked about in health assessment and promotion. Um, Melanoma is crazily enough, I was shocked. So we had a student, an athletic training student years ago, in her 30s. She was diagnosed with melanoma, and probably in, I know it was less than a month, I really want to say 2 weeks, she passed away from it. She was an African American female, loved the sun, loved being out in it. So a lot of people think African Americans don't have to worry about being in the sun because the amount of melanin you have in your skin. Lies. Okay, African Americans need to put sunscreen on, maybe not just as much as your pasty white person, but they need to all the same. Same for Latino individuals. I would say the same thing across the board. Everybody needs to use sunscreen. Okay. Um, Usually, what they'll do with these lesions is take a biopsy to determine whether it actually is cancerous and what the staging would be for that cancer. I think later we talk a little bit more about cancer, but here's kind of a general rule for treatments of cancer. The earlier you catch it, sometimes it can be just a surgical removal of the lesion, the tumor, the whatever. It can be that you've got to have surgery and radiation. Once you get further down the road in staging, like 3 and 4, you're adding chemotherapy to all of that as well. Okay? So the earlier, it can be something as simple as surgery. You move down, could be surgery, radiation, and then you keep moving, and all three get as part of the treatment. Okay? So prevention, you want to avoid the sun, especially in the worst parts of the day, which would be the middle and the afternoons, especially. Of course, right now you walk outside and it's already sunny and probably 90,000 degrees outside. You need to wear it year round. A lot of people don't think about it in the winter, but if you're outside in the winter very much, and if you're around snow, how many of you have ever been around water? Okay, wait, let me finish. You were under a tent or under something, but somehow still got burned. Nobody? I did. So the sun off the water, like if you're at the beach, can burn you. Yeah. So snow will do the same thing if you're out in it a lot during the day. Okay. So sunscreen's not just for summer, not just for the beach, not just for this heat. You want to make sure and wear protective clothing. Um, I do this a lot more than I used to, y'all. When I was a teenager, I would get out in the yard with my little radio and my towel, and I would literally rub down with baby oil and get out in the sun and suntan. Thank goodness I haven't had any cancer lesions, but it's coming. I feel it. And I do that all the time. Fake bacon. I know you white girls know what that is. Y'all know what fake bacon is. Y'all know. Getting in the tanning beds. Used to do it all the time. Loved it. It's one of the most relaxing things. Like today, if I wanted to go do something relaxing, that's what I would do. But I know better, so I'm not going to do it. Those increase your risk of skin cancers, like, I mean, hundreds of a percent getting in those tanning beds. Be careful about sun sensitizing medications. So there's a lot of them out there. Antibiotics, y'all remember us talking about? The sun can cause a problem with some antibiotics. It can actually give you like an outbreak from the sun. There's some acne medications that can do the same thing that you have to be really careful about being out in the sun because you will get an ungodly type of burn. And then just doing regular skin assessments. So I just call it mole patrol. Looking at your body. Is there a new mole? Has it changed? Is it different in color? If you don't know, try to take a picture of it. Okay, if you want to see, if you're concerned about it, take a picture of it, and then in a few weeks or a month, take a picture of it again and keep watching it and see if it changes over time. If it does, go see about it. All right, psoriasis. So this is an autoimmune disorder. So basically with an autoimmune disorder, the body attacks itself. And there's a bunch of different autoimmune diseases, pancreatitis being one of them, where your pancreatic enzymes actually start to attack the pancreas itself. But psoriasis is a dermatologic autoimmune disorder. And like I said, there's a bunch of different ones that we're not necessarily going to cover. So with psoriasis, you will see moments where they have no lesions. It actually goes away, and then they'll have a recurrence. So it's the back and forth. Permanent remissions of this are very rare. They typically don't occur. It's just kind of back and forth for the person's life. So signs and symptoms, I think this is really easy to pick out, which is one reason I chose it, because it looks very different from anything we've talked about thus far. It's got a red base, but the difference here is that inside you've got this silvery white plaque. Okay, so it's very dry, kind of crusty, but you can also see around the edges you've got these clearly defined and distinct red borders. Okay, kind of sticks out around that white area. Usually they're going to appear in skin folds. They are very common on the scalp, okay? And a lot of individuals that have psoriasis, particularly in areas that can be seen, generally have issues with that. I don't know any other way to say that. They don't, and nobody would like that. Like could you imagine having that appearance on your neck or in your scalp somewhere where it can be seen? Most people generally do not want that. So I would say hallmark sign, I don't really have it written here, is this silvery white plaque and these distinct, defined red border. Okay, those would be your two hallmark signs for this. All right, treatment. So anytime you have an autoimmune disorder, you're going to see steroids being prescribed. Okay, all that's doing is trying to keep the immune system at bay a little bit so that you're not having this big outbreak. That's all that's doing. So you'll see steroids. Again, do not memorize specific drug names. You can have steroid injections. However, they typically don't give oral corticosteroids with this because it will actually cause other problems to creep up. So if you've heard of not psoriasis. Oh my gosh. A golfer had it. Phil Mickels had it. Or Phil Mickelson. I can't remember. It can exacerbate that. It can exacerbate, the oral steroids can actually exacerbate just the normal psoriasis lesions. Don't know why, for whatever reason. It could be something with the whole first pass metabolism. I don't know. But usually you're going to see either topical or injections given with psoriasis. I think this is the last one, maybe. Not sure. Eczema is the other one you'll see a lot. It's a form of dermatitis, which means that you've come in contact with something that you're allergic to. And then what happens is, over time, people start scratching it because it itches, and it will turn into eczema. Honestly and truly, once it gets to the eczema point, if people would just leave it alone and stop scratching, which is hard to do, it would go away. Generally, it hangs around because people keep touching it, scratching it, so it hangs around. All right, so there's different stages to this. For an acute stage, you're going to see redness you're going to have a plaque, and then you're going to have these blisters. So it's hard to see in this picture, but that right there is a blister. And this kind of looks like one, but even on my screen, it's a little bit blurry. But that over there is definitely a blister. So you have these vesicles, which again have fluid in them. So once those get unroofed, you get this subacute type stage where you've got scales because it kind of crusts over where those vesicles were unroofed. You can see in both stages, subacute and acute, you've got itchiness. Again, if the patient can leave it alone, it'll probably be fine and get better very quickly. Chronic, for those who have chronic eczema, you can get areas of thickened skin that will remain that way, and then you can still have itching with that. That thickened skin is the reason you want them to stop scratching as soon as possible, okay? Because it's going to turn into a thickened area of skin if you just keep scratching. Diagnosis, they're going to do a scraping, do a microscopic look, and then what they'll also do is if you're someone who continues to get this or eczema quite often, they may want to determine what you're allergic to, so they may do some allergy testing. So allergy testing involves taking small amounts of allergen and injecting them under the skin. So basically, they have this map, this area of your skin, they have a map laid out, and they take small injections and they do it underneath the skin. You come back, and what they look at is they say, okay, and it's literally a grid pattern. And they say, okay, this box, this grid, they're having a reaction, this one, this one, this one, and then they match it up to what shots were given in that area. And they say, okay, this individual is allergic to A, B, C, D, and E. So what you can do one of two things. Either stay away from the things that cause allergic reactions in you, or you can take allergy injections, which will build up your tolerance to that allergen over time. Those injections are very expensive. Those treatments are expensive. And oftentimes, insurance carriers don't cover that. There probably are instances where they are covered, like if someone is having some really bad allergic reactions consistently, they may. I don't know that for sure. All right, so that's the way that will be diagnosed as to what you're allergic to. All right, so treatment. In the acute stage, if you come in contact with the allergen that's causing this dermatitis type reaction, you want to clean the skin as much as possible. So if you came in contact with poison ivy and that was it, you want to wash the skin really well with soap and water. What that does is gets rid of the allergen, the remaining allergen that's on your skin. It's not going to immediately start to reverse all the effects because you're already down the road with what's going on. You can do cool compresses. That just helps kind of calm the itching and maybe calm any heat that's associated with it. Oral steroids, so that Medrol dose pack, y'all probably heard that called a dose pack. That all that is a steroid that's you take a bunch the first day and you step down to fewer the next day and fewer and fewer and fewer. Again, don't know the specific name, just oral steroid. If you've got areas where you've got a bacterial infection from the scratching, because remember, if you're scratching, the dirtiest places are underneath your nail, so you're probably going to transmit some sort of bacteria. If you start to see areas where there's little pus pockets, then definitely refer them for antibiotics. And then I've got over-the-counter antihistamines. That will help with the itching. So as soon as that starts, try to take an over-the-counter antihistamine. It's best if you can take antihistamines at night. Why? Drowsiness. It makes you drowsy. There are some that make me drowsy, like Benadryl. There are some that don't. Zyrtec makes me drowsy. Zyrtec. Doesn't do anything. Helps with allergies, but doesn't really do anything as far as making me drowsy. So if they know one that doesn't make them drowsy and it works, fine, take that. But if they're taking one that's going to make them drowsy, they need to take that at night if at all possible. So it also breaks it down in subacute and then chronic stages. So for subacute stages, you want to eliminate any wet dressings that may be on them. So if they're covering the area so that that liquid is not just getting on their clothes or the fluid coming out of the vesicles, they need to change those often. We already talked about steroids. We talked about oral antibiotic. This seems like the same slide. Chronic stage. So if you get to the chronic stage where it's gotten thickened, they'll oftentimes give them stronger topical steroids and or steroid injections. Okay. And then here's kind of an at-home thing. You can use oatmeal-based lotions, if you're someone who takes a bath, oatmeal-based baths. They probably even have oatmeal-based body wash. Those are really good for individuals who have itching. Oatmeal is a great treatment for itching. Now listen, don't go home and just get like a box of straight oats. That's not going to work.